Behalf of Medicine 5 on the topic Glueless. So, presenting a 22-year-old female, a college student from Tirupattur, who presented to us with complaints of generalized fatigue since 1 month and exertional breathlessness since 2 weeks. She was apparently well in her usual state of health till 1 month back when she started developing some generalized tiredness. The tiredness was associated with progressive exertional breathlessness, such that her effort tolerance reduced about 200 meters over the last 2 weeks. The breathlessness was associated with bilateral swelling of legs and she did not have any history of orthopnea, PND, no history of any frothy urine, jaundice, or any reduced urine output. She had given a history of passing 3 episodes of black colored stools 1 day back and an episode of spontaneous bleeding from the gums, which stopped by itself. There is no history of bleeding elsewhere. There is no history of any swelling of joints, no history of fever. There is no history of any joint pains, ulcers, hair fall, photosensitivity, or color change in the fingers. And she denied any history of NSAID use in the past. And past history wise, she had multiple episodes of bleeding from her gums starting at 7 years of age, lasted until 14 years of age. And many such episodes started when she started brushing her teeth, and sometimes these episodes started spontaneously also, and these settled by itself. She also had history of developing blackish skin lesions on trivial trauma since 7 years of age. She was evaluated outside and said to have some bleeding problem, and she was advised regular follow-up for the same. And she occasionally had bleeding per rectum also, like around few drops of blood she used to notice when she passed stools in the last 2 years. And personal history wise, she takes a mixed diet. She attained menarche at 13 years of age and her menstrual cycles were normal. Family history wise, she was born out of second degree consanguineous marriage, and there was no history of any such bleeding history in the family members in childhood. And examination wise, she was tachycardic and JVP was elevated, and there was a flow murmur on auscultation. Otherwise, rest of the examination was normal. So, syndrome complex is a young female presenting with anemia and failure with a background history of spontaneous mucosal or cutaneous bleeding. So, differentials. So, for the background history of spontaneous mucocutaneous bleeds, we consider a possibility of a platelet dysfunction or a vascular disorders. Platelet disorders we consider were inherited platelet disorders like Bernard-Sollier syndrome, Liyaskar syndrome, or Chediak-Higashi syndrome, or Glanzmann's thrombasthenia. We also consider bone marrow failure syndromes with reduced platelet production like B12 or folate deficiency or an aplastic anemia. Also, we consider the possibility, being a young female, we consider the possibility of an ITP. Vascular disorders which had to be considered as scurvy or a hereditary hemorrhagic telangiectasia. And for the current presentation of anemia and failure with the history of melena, we thought of a upper GI bleed, possible causes being a bleeding peptic ulcer, gastritis, or a GI polyp or GI varus. And coming to the investigations, she had a hemoglobin of 2.2 at presentation with a microcytic hypochromic blood picture with raised RDW. She had an iron deficiency with a reduced transferrin saturation. When ferritin was low, she had a folic acid deficiency also. Her platelet counts were, however, normal, 484,000, and her coagulation parameters were within normal limits. Renal and liver function tests were not normal. And because of the spontaneous episodes of mucocutaneous bleeds, we thought of an underlying platelet dysfunction, and we did a platelet aggregometry, which showed abnormal response to platelet aggregating agents like epinephrine, collagen, and arachidonic acid, with normal response to ristocetin, which was suggestive of a Glanzmann's thrombasthenia. And flow cytometry showed an absent CD41, which is again confirmatory of Glanzmann's thrombasthenia. Stool occult blood was positive. We did thrice, and gastroscopy done showed multiple antral ulcers, which were Forrest grade 2A, for which she underwent a dual endotherapy. And we had to transfuse her with 3 units of RBCs, and last hemoglobin was 9.7. So her final diagnosis was a Glanzmann's thrombasthenia with an ISTH score of 6, and current presentation of anemia and congestive cardiac failure secondary to a bleeding antral gastric ulcer. So I'd like to make a short presentation on the approach to a bleeding disorder. So normally when there's an injury to a vessel wall, the normal pathological response is a vasoconstriction followed by platelet activation followed by activation of coagulation cascade. Clinical assessment, how do we ask a history, how do we think of a possible platelet dysfunction or a coagulation dysfunction is by the type of bleed. Usually skin and mucosal bleeds points to an underlying vessel or a platelet disorder, whereas a deep tissue bleed or a muscle or a joint bleed points to an underlying coagulation disorder. We must ask for history of spontaneous onset of bleeds, easy bruisability, prolonged bleeding from the umbilical stump from at the time of childbirth, and prolonged bleeding after tooth extraction, any significant drug history, and history of any consanguineous marriage. And 4 Ws to ask who, where, when, and what, and who's the patient, and is there any relevant family history, where all are the sites of bleeding, when was the onset of the bleeding, and the description of whether it was spontaneous or following significant trauma. Initial screening test to do for a patient who we suspect a bleeding or a coagulation disorder which is inherited includes a CBC, a platelet count, a peripheral smear, PT and APTT, and a platelet function analysis. Bleeding time earlier was considered useful, but however, currently bleeding time is not considered a proper test because there is no particular standardization and there is poor sensitivity to detect an underlying bleeding disorder. However, if we are suspecting a disorder of vascular dysfunction, there is no reliable test. It's basically we come to it as a diagnosis of exclusion when all other tests are normal. So basic abnormalities that we can detect on the screening tests. If there is an isolated increase of prothrombin time, we suspect a disorder of an extrinsic pathway, like a factor 7 deficiency. If there is an isolated prolonged APTT, we consider possibility of a factors which are involved in the intrinsic pathway, which include 8, 9, and 11. If both PT and APTT are prolonged, points to a common factor deficiency, which includes factor 10 and 5. And if there is a reduced platelet count, we can think about disorders of platelet production. If all three are normal and if we are still considering the possibility of a platelet disorder, we could think of a possible underlying qualitative platelet dysfunction. Second line investigations to send or coagulation factor assays for individual coagulation factors and platelet aggregation tests in patients who have a normal platelet count and a normal coagulation profile. And third line, just for confirmation, we can go for molecular genetics. And platelet aggregation tests, they basically work on the phenomenon of light transmission. When platelets gets aggregated, light transmission is better and there is an increased optical density. Whereas if there is a normal platelet agglutination, when there is a normal platelet agglutination, the light easily passes through the glass tube and is detected well. Whereas if there is no platelet aggregation, these platelets block the transmission of the light. And 3 steps in platelet activation is adhesion, activation, and aggregation. Adhesion is basically a process by which the glycoprotein 1b receptor on the platelet gets attached to the von Willebrand factor in the vascular endothelium. Defect in the glycoprotein 1b can cause Bernard-Sollier syndrome, and aggregation of platelets is mediated by glycoprotein 2b3a. Any deficiency of glycoprotein 2b3a can lead to Glanzmann's thrombasthenia. And this is the abnormal test that we find on platelet aggregometry. Blue is the control and red color shows the sample of the patient. Here we are able to see that there is an abnormal response. There's a proper response to ristocetin, whereas there is no response to ADP, adrenaline, and collagen, which is typical of a Glanzmann's thrombasthenia. And how do we differentiate Bernard-Sollier and Glanzmann's on a platelet aggregometry test? It is by positive reactivity to ristocetin in Glanzmann's thrombasthenia, whereas no reactivity to ristocetin in Bernard-Sollier syndrome. Ristocetin basically acts by facilitating the interaction between glycoprotein 1b and von Willebrand factor, whereas glycoprotein 1b is deficient in Bernard-Sollier syndrome, so we don't observe a response to ristocetin, whereas the response is observed in Glanzmann's thrombasthenia. So this is a disorder of glycoprotein 2b3a receptor, which is now called as alpha 2b beta 3. It is inherited as an autosomal recessive trait. Coming to case reports and case series of what is the most common presentation of patients with Glanzmann's thrombasthenia. This is one such case series done in Saudi Arabia, which showed that the most common presentation was epistaxis and gum bleeds in 88% and 62% respectively. Melena was an uncommon presentation in 38% of the individuals, and consanguineous marriage was present in 93% of the individuals. And another case series which again showed that most common presentation was the gingival bleed or an epistaxis. Newer drugs for the treatment of Glanzmann's thrombasthenia include factor 7A, which increases the thrombin levels in the body and leads to aggregation of the platelets. And multiple studies assessing the efficacy of 7A in Glanzmann's thrombasthenia showed that it is effective in controlling post-surgical bleeding and spontaneous bleeding episodes. However, it is only 53% efficacious in controlling GI bleeds. Adverse effects of factor 7, there is an increase, case reports which show increased risk of thrombotic phenomena like DVT, femoral vein thrombosis, or an intracardiac thrombosis. And treatment options available for Lanzmann's thrombocythemia include recombinant factor 7A. We have antifibrinolytic agents like tranexamic acid, and platelet transfusion is also good. And efficacy of factor 7A is as good as 91% in moderate bleeds, and combination with antifibrinolytics is as effective as 96% in patients with post-traumatic bleeding. Treatment options: patients with minor bleed, we just have to apply local measures, and antifibrinolytics will be a good option. Patients with major bleeding require platelet transfusions, and recombinant factor 7 therapies is also an option, but however, cost and risk of thrombosis is a prohibitive factor. We looked at other case reports of whether there is any particular gastric lesion or upper GI lesion which is associated with Lanzmann's thrombocythemia, which can cause a melena. There are a few case reports which we found, but however, there is no particular gastric lesion which is associated with the melena. These three case reports: one was using hemorrhage from the gastric fundus, the other was multiple gastric polyps, which was the source. The other one was there was a bleeding from the antrum with no obvious lesion. Our patient had a underlying gastric antral ulcer, for which we have put her on high dose PPIs and H. pylori eradication therapy. We have transfused her with 3 packed cells, and we gave her tranexamic acid, and we have taught her the preventive measures to avoid spontaneous bleeding manifestations. So this is just a summary of what all we saw. Patients who we are suspecting an underlying bleeding disorder: isolated prolonged bleeding time points to a platelet dysfunction. Prolonged prothrombin time in the presence of normal APTT points to a factor 7 deficiency. Prolonged APTT with a normal PT points to an underlying factor 8 or 9 deficiency, and prolonged PT and APTT can be secondary to an underlying liver disease. So learning points: one thing you must remember, if you have a high suspicion of a bleeding disorder, a normal platelet count and normal coagulation profile does not rule out an underlying platelet disorder.
Thank you. Any comments? The hemoglobin here was 2.2. At what level of hemoglobin does a person die? Do you have any thoughts? Is 2.2 compatible with life, or is it a lab error, or patient was lucky?
Depends on the age of the patient.
Depends on chronicity as well. Abrupt fall in the hemoglobin, the person may die. Here, evidently, the person has been chronically anemic, so I'm compensating. I'm getting used to it, but still, is lucky to be alive. Yeah, so such a person can have sudden death, and suddenly a young person died. I had a gastro question to ask you, because it was not exactly correct what you said. You said melena points to upper GI bleeding. So here's the question open to everyone. In melena, where is the uppermost extent of bleeding possible? So I'll ask you choices. Esophagus, esophageal lesion can cause melena, yes. Mouth, melena, bleeding from the mouth. Nose, so anything from the mouth or nose also can cause. After a tooth extraction, I can have melena. Yeah. What about the lowermost extent? You said it's upper GI bleeding. So ligament of Treats, yeah.
Yes.
Right colon cancer. So Harrison used to say, I do not know whether it's still there or not, it can come up to the ascending colon. So even the right colonic bleeding can come with melena. So uppermost extent is mouth and nose, and right colon is also described in lowermost extent. Why does the blood become black color in melena? What is the explanation?
Gets mixed with hydrochloric acid.
So acid converts hemoglobin to hematine, is thought to be there. So how does the right colonic lesion get the acid? So it's homework. You can look up as to why is it? It can't be acid. Some other explanation. Okay, very nice, interesting case. Thank you.